Hello and welcome to tonight's Immunisation Coalition webinar. The topic tonight is Pertussis, a 2025 update. My name is Andrew Minton. I am the CEO of the Immunisation Coalition, and I'm delighted to be your moderator tonight. For those of you who joined a little early, just a bit about that soundtrack. It was requested. I had to look it up. Before we get into the seriousness of the talk, just a bit of some fun facts to see if you know who the soundtrack was by. It was released in May 1982. For those of you who were born and do remember that period, it was their second single. It had a top 10 hit in Australia, New Zealand, and Canada, and was voted the fifth best New Zealand song ever in 2001. It had a brief stint in the United Kingdom. It was released during the Falklands War, so as a result of that, it was actually taken off many radio lists because it was deemed a bit of a criticism of the war in Argentina, considering that it referred to leaky boats, which was inappropriate during the naval action of the war. So, for those of you who know who that soundtrack was, it was by Split Ends, and it was 6 Months of Leaking Boat. So, an international favourite and a favourite in New Zealand. Never heard of it. Of course, I have, and I also got to see Crowded House in about 12 years ago in Sydney Opera Theatre, of which I saw Neil Finn play up the front, and he looked over my direction. So that's my connection with Crowded House and Split Ends. So with that, I'd like to now read the acknowledgement to country and start actually the webinar. So I'd like to acknowledge the traditional custodians of the various lands of which we work, particularly the Gadigal people of the Sydney region where I'm from, and pay my respects to elders past, present, and future. I'd also like to celebrate the diversity of Aboriginal peoples and their ongoing connections and the various ongoing cultures and the various connections they have to the animals, the lands and waters of Australia. Just a bit of housekeeping. Tonight's presentation is brought to you by Dr. Andrew Beard, and I'll introduce him in a minute. He has around about 40 minutes to present his topic, which should leave us plenty of time for questions. If we don't manage to get to your questions, and if you could submit those maybe, third of the way through, just so there's the opportunity to cover your question during his presentation and not asking the question too early. But if we don't get to all the questions, we will write written responses and provide those together with a recorded webinar in about a week's time and send them to you. With that, please type in your questions in the Q&A tab at the below, and you're welcome to make comments in the chat. This is a recorded webinar, so everyone will be on mute, and as I said, the recorded webinar will be available on our website in about a week's time. And at the end, there's a small 2-minute evaluation, so if you're able to fill that, it'd be great. We do look at those, and we're always looking to improve our educational activities and with continuous improvement. So tonight I would like to introduce our guest speaker. His name is Dr. Andrew Beard. He is a general practitioner at St Kilda Medical Group in Melbourne, and is also a medical advisor for a medical defence organisation. Andrew is a member of the Immunisation Coalition and contributes regularly to the Primary Care Education Committee, where we look at particular events over the next months and within the year, and he provides his input from a GP's perspective. Within that primary care committee, there's also nurses and pharmacists to cover primary care. He has a background in rural general practice and is passionate about education and providing practical medical education to healthcare professionals. So with that, I would like to invite Dr. Beard to present on pertussis, and we look forward to hearing from him. Thank you, Andrew.
Good evening, and everyone. Many thanks, Andrew, for the welcome and for the invitation to present this evening for the webinar. Many thanks. So the objectives for this evening are we're going to review pertussis epidemiology. We're going to look at the vaccines that are used to prevent pertussis. We're going to look at their effectiveness and their coverage across age groups and indications. We're going to review pertussis vaccination in the context of the National Immunisation Programme. And we're going to look particularly at the benefits of pertussis vaccination in the older age population and the role of primary care in improving vaccination rates. So got two performers I want to introduce for this evening's webinar, and the first is the pertussis bacterium in this infographic. So this is our candidate for tonight's presentation. And the second performer for this evening is Jules Bordet. Jules Bordet, born in 1870, died in 1961 at the age of 91. He was a Belgian immunologist and microbiologist. He isolated the pertussis bacterium in 1906. In addition to being a microbiologist and an immunologist, he was a teacher, a philosopher, very interested in literature. He was an artist, and he had considered a career in law, but he decided to take medicine instead. So interestingly, we refer to the bacterium as Bordetella pertussis, but in fact it should be Bordella pertussis, not Bordetella pertussis. The T is actually silent. So perhaps just to introduce the illness, I'll talk a little bit about the clinical course of pertussis. So typically divided into the four stages of the incubation period, the catarrhal stage, the paroxysmal stage, and the convalescent stage. So the incubation period, typically 14 days, range of about 6 to 20 days. Exclusion is 21 days after the onset of cough or after 5 days of antibiotic therapy. For children less than 7, unimmunized contacts in the same room, they should be excluded for 14 days after last exposure or after 5 days of antibiotic therapy. Pertussis is a highly communicable bacterium, particularly in the catarrhal pre-cough stage, with really a 100% attack rate. So unimmunized individuals are going to get the infection. Transmission is by respiratory droplet. The bacterium does not really survive very well on surfaces, so it's not by fomites, it's by droplets that it's transmitted. And from about 3 weeks after the onset of the cough, effectively it's not communicable. And typically after 5 days of antibiotic will not be communicable. So what about antibiotic treatment? Antibiotic treatment eliminates Bordetella pertussis from the nasopharynx, minimizes transmission. It is recommended if the diagnosis is made less than 3 weeks after the onset of cough. Prophylaxis can be considered. It's rather complex, depends on context, situation, may be considered for infants, for pregnant women who are at greater than 36 weeks of gestation. And because it is context specific, this is really the situation where we will be getting advice. The antibiotics that are available, well, the recommended vaccination is azithromycin, taken once daily for 5 days. Unfortunately, it's not subsidized under the pharmaceutical benefits scheme. Other macrolide, clarithromycin, that is subsidized for respiratory illnesses, or alternatively, good old cotrimoxazole. Roxithromycin and erythromycin are not considered to be effective for either treatment or prophylaxis with Bordetella pertussis. So I'm going to look a little bit now at pertussis across age groups. Just to sort of set the scene, here we have a chart. This is from the World Health Organization. It's current, and it's showing what has happened with pertussis since the year 2000 up until last year. Looking at the number of reported cases, and we can see that something very significant has happened in the last year, with the worldwide cases reaching around about the 1 million mark in the last year. Looking now at Australia and looking at over the last 30 years, we're looking at the National Notifiable Disease Surveillance System. And what we can see from this is that the peak again that has occurred recently in the last year, and we'll also see that peaks seem to occur every 3 to 4 years. So there do seem to be epidemics every 3 to 4 years. The chart on the right breaks down the notifications in Australia by age group, and as we would expect, this is skewed towards infants and children, but it does occur in older people, does occur in adults as well as in children, and this will be something we'll be discussing a little bit later on. Now, you might say, what's influenza doing here? I've put influenza really just to give us context. So in terms of our respiratory illnesses in Australia, influenza is a greater concern than pertussis. So this is data for so far this year in Australia, and we can see that in children, in the sort of the 5-year-old to 9-year-old age group, we're getting over 50,000 notified cases of influenza. So 50,000 in that age group. Now I'm going to move to pertussis for this year, and considerably less, so considerably fewer. So in that 5 to 9-year age group, we now have about 4,000 compared to 50,000, 4,000 cases of pertussis. I'm now going to walk us backwards through the years of the pandemic, really to show what has happened over the last 5 years. 2024 was a big year for pertussis, and pertussis scored more than 20,000 cases in the 10 to 14-year-old age group. But let's step back into the COVID pandemic and see what happened. So going back to 2023, look at those numbers. They plummeted. So that 10 to 14-year-old age group, still the peak age group, but down to about 700 cases. Let's step back to 2023. And interestingly, we've almost lost the age group differences. So not only have numbers plummeted, we can see the peak number there in the infants under the age of 4 of about 50. But similar numbers across all age groups. And dropping back to 2021, so really the sort of the start of the pandemic, and again very low numbers across all age groups. I think the peak there, not in infants, but actually in 30 to 34-year-old adults at about 50 in 2021. And stepping back to the sort of really just the very start of the pandemic in 2020. So we hadn't really got into all our lockdowns at this stage. So the numbers are higher back in 2020. So something was happening during the pandemic, and it wasn't the vaccinations. That was our physical distancing and our lockdowns. And it wasn't just pertussis that was minimized during that period. And here we go. This is pre-pandemic, and these are figures that are more representative of what we saw on that earlier slide across the last 30 years, with the peak incidence again in the children age groups, and again the 5 to 9-year-olds of about 2,500 in 2019. So moving away to looking at adolescents and young adults, looking back to 2009 and looking up to 2020, and we can see again that with pertussis, that there's been a decline over that period of time in the notifications and therefore incidence of pertussis. This is the years 2013 to 2018, and this is again to show that the age groups that are predominantly affected by pertussis are infants and young children. So putting all that together, the national all-age incidence of pertussis notifications, as shown in the previous chart, 2013 and 2018, was about 63 per 100,000 persons, and that has decreased by about 40% compared to the period between 2006 and 2012. So something has happened that has enabled a reduction in that incidence of pertussis. Infants under the age of 2 months had the lowest notification of all age groups under the age of 5. And the highest notification rates were in the pre-adolescents, the 9 to 11-year-olds. Very significantly, both notification and hospitalization rates in indigenous children have been about 3 to 8 times higher than the rates in non-indigenous children across all age groups under the age of 5. As mentioned earlier, epidemics occur every 3 to 4 years. Most cases occur during spring and summer, so we're moving into the pertussis season. The pertussis incidence increased from 2005 to 2010, and there were a phenomenal 57,223 cases last year. That's 50% higher than the previous peak of 38,000 in 2011. Again, so our timescale now, we're looking back over the last 35 years, and again, showing you can just about wake it up from those peaks, that peaks are occurring every, 3 to every 3 to sort of 4 years. The big peak, 38,000 in 2011. We haven't shown the last year's peak, which again was 57,000. So vaccine effectiveness. Pertussis-containing vaccines protect against severe and typical pertussis. They provide substantially less protection against the milder coughing illness. The DTPA vaccines have a vaccine efficacy of over 70%. For preventing milder symptoms and over 80% for preventing the typical disease of pertussis. In adolescents and adults, so this is with the reduced antigen content, that's the lowercase pa. These pertussis-containing vaccines are immunogenic, also in older people, and the vaccine efficacy has been quoted as about over 90%. Vaccinating women in each and every pregnancy reduces the risk of pertussis in the pregnant woman, but also in their young infant. It's a bit like immunization in advance. The baby is getting immunized before the baby has been born by passive immunization, by the transplacental transfer of high levels of pertussis antibodies, so that when the baby is born, the baby already has preformed maternal antibodies on board. And this has been shown to have very significantly reduced the incidence of pertussis disease in infants under the age of 3 months. That is, infants who would otherwise be before they have got their Infanrix or Varilix vaccine. This is a chart showing the National Immunization Program schedule for pertussis-containing vaccine. So we have a 5-dose schedule for infants and children. And then boosters for adolescents and also for pregnant women. So the 5-dose schedule is the 3-dose primary course, and then the boosters at 18 months and at age 4. The National Immunization Program also provides coverage as catch-up for children under the age of 10 who've missed one or more doses. And the target is 95%. I'm now going to show a series of slides which will demonstrate the annualized percentage of Australian children who have been vaccinated to date. I'm really only going to sort of want to focus on the Australian total, not the state and territory totals. So if we look at all Australian children immunised by 12 months until June this year, about 92%. And this again, this is for pertussis, so it's the first column. So all Australian children immunised by 2 years of age to June 2025, about 91%. And the annualised percentage of all Australian children immunised by 5 years of age to June of this year, about 93, about 93.5%. So not quite at the 95% mark that we're looking for. Looking now for trends over the last 5 years, 2020 until last year. So this is for all children. We look at the figures, they're all over the 90% mark, but they're all trending down the way over the last 4 years. So vaccination coverage has been decreasing at all landmarks at the age 1, age 2 and age 5. And if we look specifically at Aboriginal and Torres Strait Islander children for the same, over the same period, 2020 to 2024, all are lower across all ages and also across all years. So something is happening. We are getting fewer children vaccinated, and particularly that is the case with Aboriginal and Torres Strait Islander children. So moving from children to adolescents, vaccination is recommended for all adolescents aged between 12 and 13. And this includes refugees and humanitarian entrants. What about the numbers there? Well, if we look at all adolescents, and these are the data for 2023, only 85%, and for Indigenous adolescents, only 80.4% had been vaccinated by then. So now we've talked about infants, children, adolescents. What about adults? Well, uh, if we look at the Australian Immunisation Handbook, in other words, what does the Health Department recommend? All adults who want to reduce their likelihood of becoming ill with pertussis are recommended to receive a pertussis-containing vaccine every 10 years. Um, Adults who need a tetanus vaccine are recommended to receive a pertussis-containing vaccine rather than the DT vaccine. DTPA is not funded for adults except for pregnant women. This became jurisdictional 10 years ago and has been on the National Immunisation Programme since 2018. Other groups that are recommended, other adult groups, occupational risk, so healthcare workers, childcare workers recommended to have the vaccine every 10 years. Travelers recommended to have the vaccine every 10 years. And those who are in contact with or carers for infants under the age of 6 months, they should receive the vaccine at least 2 weeks before their initial contact with the infant. And people who've had pertussis, natural immunity wanes. So natural immunity is not forever, and people who've had pertussis should be vaccinated. When is not clearly defined, but they should get it at some stage. What do we do about an adult who's not had a primary course? Interestingly, that's not defined. Should they restart a primary course, or should they be treated just as if they've had a primary course? And if anyone has the answer to that, I'd be interested to know. And this is just the concept of cocooning, so to protect the vulnerable infant. So people who are around the infant getting vaccinated to protect themselves, but also to protect the infant. Many European countries recommend the DTPA vaccine every 10 years for all adults, but not funded. And how much does it cost? Well, DTPA about $30 per dose. If combined with the poliovirus vaccine, then about $60 per dose. Some of you will have heard of a monovalent pertussis vaccine available as a booster. Well, not in Australia. It's called Pertugen. It's a genetically detoxified recombinant two-component acellular pertussis vaccine. So it has the pertussis toxide and the fimbrial hemagglutinin components. It is licensed for use in Thailand and Singapore, not licensed in Australia, although trials are being conducted in Australia, and so far it has been shown to be non-inferior to Boostrix. What about vaccines in older persons? We have in Australia no systematic surveillance system for checking and monitoring the vaccination for pertussis in older people, despite the immunisation register. A study which was published in the MJA last year did use the registrar, the Australian Immunisation Register, to indicate that only about 20.8% of Australians aged 50 and over had received a pertussis-containing vaccine. And among adults vaccinated for diphtheria tetanus, only 2/3 had been given the pertussis-containing vaccine. So missed opportunity, or perhaps cost, that was an issue which prevented the pertussis vaccine being given in those cases. So we're saying that adolescent pertussis vaccination, we're saying around about 80 to 85%, not 95%. So students may miss the school immunisation visit. So all providers have a responsibility to ensure that students catch up need to be opportunistic. And as practitioners, we should take every opportunity to check the register to ensure that adolescents have received the relevant booster. Going to now look at aging. Healthy aging in the context of pertussis. So, why vaccinate adults? Well, pertussis is not just a childhood disease, and there's a reservoir in the community, and there's immunosenescence. This is the concept of the age-related deterioration in the immune system. So, further than that, data suggests that pertussis in the elderly and those with associated underlying chronic conditions can result in very significant morbidity, mortality, and costs. So, with persons over the age of 50 who develop pertussis illness, more than 10% will be, admitted to hospital and are likely to develop further complications related to the illness. This is a snapshot from South Australia in 2008, and the purpose of this is to show that pertussis does indeed occur in older people. In fact, 66% of notifications in that year in South Australia were in people aged 25 and older. So we know that pertussis vaccination, neither pertussis vaccination nor natural infection confer lifelong immunity. So adolescents and adults with waning immunity are the main reservoir for pertussis in the community. So they're at risk to themselves, but also to people that they're in contact with in the community. Why? What is immunosenescence? Well, our T cells get exhausted. There's a decrease in the CD8 cell population. There's telomere shortening, and there's a decreased response to all vaccines. So here's what happens. The impact of immunosenescence and increasing frailty, leading to an impact on disease and ongoing disability. We have vaccines for prevention for influenza, pneumonia, shingles, and pertussis. But in Australia, we're not doing all that well with regard to older persons, as we indicated earlier from that study in reported in the MJA. Only about 20% of older persons getting a pertussis containing vaccine. We do better with pneumococcal vaccine, shingles vaccine, and with influenza vaccine. So pertussis in adults is three things happen. It gets missed. We don't think of it. We get misdiagnosed. It's just another respiratory illness, and it doesn't get reported. So surveillance is impaired as well. And the diagnostic challenges. The best testing is in the early weeks of the illness, which may be before it's suspected, and that is with nucleic acid amplification testing, or PCR. This has the best sensitivity, but has poor sensitivity if antibiotics have been taken. Culture is the gold standard. It's good specificity, but poor sensitivity. Serology is only helpful at least 2 to 8 weeks after cough onset. Pertussis vaccination does not produce IgA, so there isn't any concerns about misinterpreting immunoglobulin based on infection and based on vaccine response. Okay. So looking at responses to the Bordetella pertussis vaccine, looking at is it effective? This has shown that infection does occur, probably between 3 and 8% in older adults. More than 50% of people with the infection were symptomatic. Symptomatic pertussis occurs in elderly individuals, so elderly people need to be considered for protection. The significant issue with older persons is comorbidity, because comorbidities are more prevalent in older persons and also make older persons more likely to get pertussis infection and to have more severe illness and complications. So, and what this slide shows is that this is based on United States of America data, is that the vast majority of people hospitalized, older persons hospitalized with pertussis had other conditions. So comorbidities, particularly respiratory disorders, obesity, smoking, diabetes, cardiac disease, and renal disease. Going to look a little bit more now at the effectiveness of pertussis vaccination, and to sort of summarize the figures on that chart, the vaccine efficacy doesn't last all that long. So by the time you're getting to about 8 years after vaccine, vaccine effectiveness is less than a half. So that's why for immune efficacy, vaccine needs to be boosted every 10 years. And the same applies after a natural infection as well. Okay, so what can we do as practitioners? Well, we talk with older people about the significance of pertussis infection, the relevance to themselves, to their families, and we can address misunderstandings about the nature and about the prevention of pertussis as well. Here on the chart, you'll see on the right-hand side, the table 2, some of the misconceptions that people may have and how we can correct those. So yes, the importance of having a pertussis vaccine. Vaccination in childhood does not give lifelong protection. Pertussis vaccine is effective. I've had pertussis in the past, so I don't need a vaccine. Yes, you do. So correcting misunderstandings. What other strategies? Well, ourselves, are you up to date with your pertussis vaccine? What about family members? What about our communities? What about our governments? And who should be taking action? Well, all of us. So all of us here tonight as healthcare practitioners across whatever our specialties may well be. We've all got roles in promoting and administering the pertussis vaccine. So pertussis is a disease that occurs across all age groups. It's underreported in adults, frequently missed or misdiagnosed. It is associated with significant morbidity and mortality, and it is eminently preventable if we recognize people who are at risk, and we provide advice and appropriate vaccination for them. Okay. I think I've just about run out of time. I was going to talk for 40 minutes, and I think my time is up. Uh, I think I would close there, and I'll hand back to Andrew, and I'll ask Andrew if um, you'd like to ask any questions.
Thank you very much, Dr. Beard. So great overview covering, epidemiology, infection rates, vaccination rates, efficacy, risk groups, and so forth. So really a great overview. We do have a number of questions, and we have 20 minutes, so we have plenty of time. But one of the questions that came up was we have, that the 10 to 14 age group has a high infection rate. There is a year 7 school program, and I think the coverage rate is in kind of the high 70s, maybe early 80%. And then we have the 0 to 4, which is also has a high infection rate and would be the most vulnerable, particularly in the under twos or under ones.
Mm,
But we do know that the vaccine coverage rate as part of the childhood immunization
mm,
schedule
yes.
is high. It's not 95%. It is coming down, and
Mm,
it does differ between 1, 2, and 5 years. But my question is, should we spend more time ensuring that we vaccinate more of the year 7 students, that sort of 12 to 13 group, because they seem to be the transmitters? Or should we spend more time focusing on getting the vaccination rate up in the under fives towards 95%, or both?
Fabulous question, Andrew. And I think the easy answer is both. But that's really probably dodging the issue. And I think if we're going to, if we want to emphasize one or the other, then we know that we need to address the pool or the reservoir of pertussis that's in the community. And that's the adolescents and the adults. So in terms of whom we should be focusing on, it would be really helpful to increase the coverage in the adolescent groups. So that's not to ignore the aim of getting 95% at those 1 year, 2 year, and 5 year marks in the young children, but 80% in the indigenous adolescents and 85% in the all adolescents is way too low. So we've got a significant reservoir amongst our adolescents. So that would if we're going to make a choice between those two in terms of where to focus, then we should be concentrating on adolescents. Yes.
Okay. The other question is, we have a 5 dose schedule up to 4 years old, and then there's a break until year 7, which is 12 to 13.
Hmm.
There is, it's a sort of a waning of immunity between those two periods. Is it time for a review of whether or not year 7 is the right time, or maybe we should bring that into year 6?
Fabulous. Again, a really good question. I don't know the answer to that. That's right. Should the booster, another the sixth dose, should it be given a year sooner? Would it make any difference? I don't know. And all I can say, internationally, that's not happening. The adolescent 12 to 13 is fairly consistent across the globe. So I'm not aware of any studies or projects that are looking at an earlier booster. So yeah, I don't know. And I think it's on the table, but I don't know.
Okay. A question here from Robin Morey. If a woman has received a DTPA booster after 25 weeks in pregnancy and is exposed to disease after 36 weeks, does she still need antibiotic cover?
Yep, and the answer to that question is maybe. And that was when I suggested that in terms of prophylaxis, being over 36, being at over 36 weeks gestation, whether vaccinated or not, it would be considered. And it would depend on many, many other factors as well. So there isn't a single right answer. It would depend on the pregnant woman's, potential, comorbidities. It would depend on the family situation. And this is one where you would be taking advice, from, either from an infectious diseases physician or even from a pediatrician. So you can't, there isn't, it's not possible to give a definite answer, but it needs to be considered.
Okay. Should household contacts be vaccinated? I'm just going to read the question, or or should be given a course of antibiotics as cheap chemo prophylaxis.
So the in terms of prophylaxis is with the antibiotic if that is considered to be sort of at high risk. So individuals who have not been vaccinated, then yes, they would it would be appropriate for them to have the antibiotic. That's correct. But giving them the vaccine itself will not actually help in the short term. You need antibiotic prophylaxis to do that, but it would be appropriate for the unvaccinated household member.
Pert again, so you did touch upon that. So that's the monovalent pertussis
Hmm.
vaccine. So where's the advantage of having the monovalent pertussis vaccine as opposed to what we already have, particularly for pregnancy?
Yeah, the manufacturers would suggest that it's twofold. One is that you're not giving additional diphtheria and tetanus toxoid, and the second is that their genetically modified or detoxified two-component vaccine is actually more effective, and that there is some evidence from the studies that have been done and are in progress, that it may be better than non-inferior, if that makes any sense. That it actually may be more effective than the DTPA. So that's the argument. It is that it's more effective,
Okay.
maybe.
Okay. Even after five dose schedule of pertussis, why do we want to immunize pregnant mothers, particularly when they're, I think the period in the second trimester, 20 to 32 weeks, don't they have a lifelong immunity to pass antibodies on to their babies?
They do. That's true. But do they have enough? And I think that's it. So that's the idea that vaccinating a woman during the second trimester is a booster. So it's boosting the mother's antibodies, and therefore the transplacental antibody transfer is going to be higher than if she had not been vaccinated. So that's the idea of it. It's quantity. So it's giving it's less so to protect the mother. It's more so to provide the baby with antibodies on board at birth, and particularly to cover that vulnerable period before the infant can be vaccinated at the earliest age of 6 weeks.
Okay. I've heard the efficacy of pertussis is another waning question, can wane after 5 years, and that is
Correct.
true. So that is true. Should the father of a newborn also get a booster? She does say every 10 years or earlier as recommended.
Yeah, the every 10 years is the recommendation. So whereas the mother would be getting the vaccine in every pregnancy. So if a mother and her partner have 4 babies in 4 years, a mother will have had 4 vaccines in that time, but father will have only had one. So you don't vaccinate the father in every pregnancy because he's not transferring antibodies to the baby.
Do you see a role for pertussis PCR testing at the point of care, given how communicable the bacterium is, particularly in the last 2 years.
I think that would be yes, that would be a great idea. And I think we alluded in the presentation to the difficulties of diagnosis, that it's missed or misdiagnosed and underreported. So I think if that would be much better if we could see a young person or adult in that early stage of the illness, which is when the PCR testing is most effective. That could be done there and then. That would be very helpful. What I don't know, and the follow-on question would be how much would that cost, and I don't know. I think cost may be the barrier, but otherwise that would point of care testing would be very helpful.
And where would that point of care testing best be?
Um,
Hospitals, urgent care clinics,
all of the above.
all of
So
the
I mean,
above?
like, all of the above.
Yeah.
Any primary care encounter. So it could be the pharmacy, it could be your GP, it could be the emergency department. Could even be self-testing. I mean, it's. I think all of those would be possible. All would are likely to improve the identification of people who have. Pertussis, and that then enables treatment that further reduces the severity of the illness, but also reduces transmission, and also enables infection control procedures such as isolation to be implemented as well, and particularly for protecting children who may attend school or attending childcare.
So you showed a slide looking at historical infection rates, laboratory confirmed infection rates, right back to I think 1991 or something
Mm,
like that. Now it does appear that outbreaks occur every 3 to 4 years,
yeah.
um, and they kind of last. I've looked at them myself. They kind of last for more than 1 year, normally two, sometimes three.
Mm.
So why is it that we have this waxing and waning of every 3 to 4 years? What's the reason for that?
I wish I knew.
Okay.
I've got no idea. And no, I was anticipating that question, and I had been trying to do I had been looking,
Oh,
and nobody knows. It's observational. That's what happens. There doesn't it doesn't appear to be related to any of the things you would expect. It's not related to vaccination coverage. It's not related to the contact or shutdown or lockdowns or people's social activities. It's just the way it is. So I don't know. Don't know. You,
yeah.
you know, Andrew, have you got any ideas?
No, but we should try and flatten the curve. Remember that saying?
Yes, flatten the curve. Yes. Yeah.
Um, well, I'm sure someone has the answer, um, but yeah, I don't. Um, we have a COVID-19, RSV, and influenza A and B rat tests, and
Yeah.
we used that here in the house a couple of days ago. Could pertussis be added to a test, and would it be accurate?
Um, I wish it would be. I think that would be good. As we've said previously, I think that would improve the identification of pertussis, and then that enables appropriate management in terms of isolation, and also in terms of treatment. So yes, my question is why hasn't it happened? So I don't know whether that is whether it's just it's not feasible to apply that in that form, or whether costs are maybe an issue, or a bit of both. I don't know, Andrew.
Okay. Um, another pregnancy question here with regards to vaccination at 20 to 32 weeks,
Mm.
but you can be vaccinated right up to delivery, of course.
Of course.
So in each pregnancy, you don't have to be revaccinated. It's just within that 10-year period, correct?
You will be with each pregnancy. It doesn't matter how many pregnancies you have, you get vaccinated each time. So
Each time.
each time, absolutely each time. So you're absolutely each time. So you're getting a fresh boost with each pregnancy. So the baby is getting the maximum transfer of antibodies. So a woman, if a woman has 10 babies in a 10-year period, she'll have had 10 pertussis vaccinations.
Okay. Is it only Adacel that has a 10 years coverage, or does it also apply to booster?
Same. Exactly the same.
About
Yeah,
the same. Yeah.
essentially the same. Yeah.
Okay. What's the time? Just a couple more questions. I'm just going to read it out. Why erythromycin is not effective? Um, I don't quite understand the question. It's misspelling. Um, is erythromycin not effective against pertussis? Maybe we
It
just
just
say.
isn't. It just isn't. Look, I can't quote the. I mean, it'll have some sensitivity, so I'll just pluck a figure and say it might be 40% effective, but it doesn't meet the sort of the level of efficacy which would be regarded as an appropriate treatment. So there may be some response for some people to erythromycin, but not enough. For it to be a recommended treatment. It used to be, 20, 30 years ago, that was a standard treatment, but it's not. And the same applies to roxithromycin. It's just that the sensitivity of Bordetella pertussis to roxithromycin and erythromycin is low. Yeah.
Maybe just the last question before we wrap up. It's a question around pruning. So, with friends and family of a pregnant woman, um, uh, how wide do we need to cast that net? I guess it's based on how frequent the friends and family visit.
Yeah.
Uh,
Yeah,
you know,
and with I mean, the argument would be, yeah, you cast the net widely, because it only takes one encounter of an adult who has the Bordetella pertussis bacterium. It only takes one encounter because we know it's a highly infectious, highly contagious. It only takes that one encounter. So if you've got, your great aunt from, interstate who's visiting for one day, then it would be very advisable that your great aunt or your great uncle from interstate has been vaccinated as well.
yeah, better to be safe than sorry. And
Yes, absolutely.
you're
Yep,
really talking
absolutely.
about the most vulnerable, highest
Absolutely. Yep, agreed. So
people.
I think it's that would be advisable to do that, everyone. Yep.
Okay, all right. Well, thank you very much, Dr. Beard. A great overview, and thank you very much for answering all of the questions, and
Thank
also
you.
for the audience for their engagement. And as I said, if we will be publishing the answers to the questions a bit more detail, although we have covered a lot of them already, and that will be available in about a week's time. So just to let you know that the next IC webinar, IC as part of the disease-specific webinars will be on the 19th of November. So that will be on shingles, presented by our Associate Professor John Litt. So look for that. And also next week, we have the Alan Cripps Pneumococcal Disease Memorial Webinar. There are some changes, as you know, to the schedule with the addition and substitution, if you like, of Prevnar 20 with Prevnar 13. So Prevnar 20 is now listed as of 1st of September. So we'll be one of the first to present on that next week on the 24th. And look, there's a few other webinars coming up, and look, we also have some podcasts on our learning management systems and clinical newsletters coming up. So we will communicate those to you. So stay tuned. From me, again, just thank you very much. I hope you enjoyed the soundtrack, bit of New Zealand for you. And Andrew, if you'd like to say a few words, and we'll wrap up and say goodbye.
Thank you very much, Andrew. Thank you, Anastasia, behind the scenes for organising things, and many thanks everyone for coming along this evening and for your questions and for your interest. Thank you, and stay safe and have a good evening.
Thank you and good night.